Michael was our 7th nurse practitioner registered in New Zealand, some 16 years ago. So just yesterday, Michael. She has extensive experience as a leader, clinical leader and researcher. Her interests include care of the older adults in the community and residential care and advancing nursing practice. Tonight, Michael will be talking about best practice in palliative care. I'm sure through this journey that we will all learn some gems that can help our patients live as comfortably as possible.
Thanks, Catherine. It's welcome everybody. It's fantastic. I'm in actually Hanmer Springs at the moment, on doing a sabbatical. So I've gone to the Springs to get my head clear so I can have something to say to people over the next 6 months. Okay, great. So I was asked to talk about palliative care for rural nurses. It's a bit daunting because I could, there's about 3 days worth of stuff we could talk about. So I'm gonna basically go kind of on a roll here and talk about some things, and I'm really happy at the end to answer some questions or have a discussion or that kind of thing. So first of all, I work in residential aged care. I've done research in end-of-life care in residential aged care just recently. We had a study called the Elder Study. That what we did is we looked at deaths in residential aged care. Just by the way, about 43% of all deaths happen in residential aged care for all deaths in New Zealand. So the question was, that was kind of a shock to a lot of people. And the question is, okay, so what's the quality of those deaths? Well, actually, there's a few things about those deaths that are interesting. Is we divided the sample into cancer, dementia, and chronic illness. And as you can see there, we have discomfort, we've got pain, we've got restlessness, shortness of breath, choking. This is the last week of their life. This is a very quick overview of a very long study. But basically what you can see is there isn't a whole lot of difference in that last week of life, regardless of what you're dying from. And I think that's one of the key messages I'd like to kind of make sure that we get across today is that whether you're dying from dementia or you're dying from cancer or you're dying from heart disease and stroke, dying symptoms aren't that much different no matter where we are. Now, interestingly, then the question is, okay, so how is the quality of death in New Zealand? So one of the things we were able to do with the Elder Study is to compare New Zealand over there on the left. We used an instrument. It was a validated instrument that was also used in those 6 other European countries. And as you can see, New Zealand did pretty well. So, we actually, the question I got from the reviewers of the paper that we just published in BMJ Geriatrics was, BMC Geriatrics was, so why is New Zealand doing so well, basically? And I think there's several things. And one of the things about New Zealand is that we've been, I think because of our size and because we have a centralized Ministry of Health, we've been looking at end-of-life pathways for over 10 years in New Zealand. And I think that, in my opinion, has helped a lot. Now, there's a lot of controversy about end-of-life pathways, and I'm not going to go there tonight because I don't really have time. But I do think that that's made a difference in New Zealand, and just initiatives that have been helpful. So the first thing we always have to talk about when we talk about palliative care, before we go, my internet connection is a wee bit unstable. Back, I hope. My internet connection can be a little bit unstable here in Hanmer. So one of the things we have to think about, first of all, is goals of care, advanced care planning, advanced treatment planning, whatever you want to call it. Again, I could do a whole hour on this, but I'm not going to. It is a very, very important thing, particularly for anybody who is possibly in the last stage of their life. That would be anybody with chronic illness. That would be anybody with dementia. That would be anybody that's older. I'm a real advocate for doing advanced care planning and do it on a systematic, regular basis in the facility that I work with. We have a family meeting every 6 months. We have a very systematic forum. Again, I don't have time tonight to go into how we do it. But one of the things I think is important for us, particularly in residential aged care, is to say, okay, so how aggressive are we going to get as things go downhill? So certainly there's CPR, EPOA, that's really important, but it's the least important in my opinion. It's the level of care for me that's the most important. The level of care, so we've got people that we're not going to cure their dementia. Therefore, when they get into the last stage of life and we need to do palliative care, the kindest thing that we can do is just keep them comfortable, versus I have other people who they might have a mental illness, a long-term mental illness, but other than that, their quality of life's pretty good. And so they would recover from illness. So yes, we're going to do more. So it's about kind of resilience. Part of it is resilience. And part of it is certainly what we call goals of care. What are our goals here? Really is incredibly useful conversations. Now, this is part of the tool that we use. We ask all those questions, but what we also do in these family meetings, which I find incredibly helpful. So it's kind of a merger of the National Advanced Care Planning document, which is really excellent. It's really great. It's just long, and for those of us in clinical practice, sometimes that length can get in the way of us doing it. So what I will ask families, and I do work with a lot of people who don't have the capacity to talk to me, so what I'll ask families, or even you could ask the people that you are doing the ACP with, is what matters. What matters to them, what made their life meaningful. What that does for me when I'm having this advanced care planning goals of care discussion, it takes it out of, do you want me to start your heart, to, it takes me to, who are they? Tell me more about them. It makes it a much more meaningful, lovely conversation. And so that when I call them at 4 o'clock in the morning because their father just had a stroke, I know them, they know me, they know that I know their father. So I really do encourage whatever you have to do to get that advanced care planning working in your system. It's a really important part of my work. Now, I'm going to talk a little bit about how do you identify people that need palliative care. So there's a couple of tools that I'm just going to discuss and some of the pros and the cons. There's a thing called the Supportive and Palliative Care Indicators tool called the SPICT tool. There are several palliative care organizations that use this tool. If you look at this from the NHS, and if you look at, I'll talk about those 6 things. The performance status is poor or deteriorating. The person is in bed more than 50% of the time, and reversibility is limited. So that's the first indicator. The second is dependent on others for most care needs due to physical and or mental health problems. The third one is 2 or more unplanned hospital admissions in the last 6 months. The fourth one is significant weight loss. And I will talk about this. 5% in a month or 10% in 3 months is kind of my limit for frail older people. And a low body mass index, persistent troublesome symptoms despite optimal treatments and underlying condition. And then the last is patients asked for supportive palliative care. So this helps to hone in, particularly in primary health care, those people that might, 100% of the people I work with would fit this. So it doesn't really work. Oh, my internet connection's going unstable. Let's see how this goes. Okay, I should be back. This doesn't really work for my population, for my very frail, fragile older people. And in fact, you can see there that hospitalized older people, it was positive 48% of the time on whether they had died or not. So basically what it says is, I do the tool, let's go back in a year and see if they've died. Well, you might as well have flipped a coin because, 50% of them died and 50% of them didn't. So it wasn't real helpful for older people. I do think it would be helpful in a primary healthcare situation or other situations that you might find yourself with, just for people that have been really healthy and then maybe have cancer or another life-limiting illness. This might be helpful. For people that are already frail, not so much. Now, the question is, what about the surprise question for predicting death? some of you know this question. It's been used a lot. It is, would you be surprised if this person died in the next 6 months, as some people use it like that, or would you be surprised if this person died in the next 12 months? Now, I've been reading up on this because I'm on my sabbatical and I get to read a lot, so I'm reading a lot. Very nerdish thing to do, but I am reading about the surprise question. So one of the things about it is, if you read, there's a woman named Joanne Lynn, and she's done some fantastic work about trajectories of care at the end of life. And her comment on the surprise question was, it was never meant to be a predictive tool, but it was put into other tools to be a predictive tool, which I thought was quite interesting. So she was she's done some work on this, as well as this article that I have here that I'm referencing here. So it is, again, you got to think of from being really healthy to dying of cancer. Yes, a surprise question might be helpful. If you start with somebody who is very frail and then try to predict who's going to die, it isn't very helpful. And what they said in this article was the surprise question performs poorly to modestly as a predictive tool for death. What we found recently in some work that we've done with the SHARE project is we used a frailty tool and the surprise question tool, and the SPICT tool. And we found that the frailty index for people in aged care was much better than the SPICT tool. And again, we've already discussed what the issues are. So it's an interesting thing about whether you should use the surprise question. I will say, in my population of older people, one of the things that I'm definitely getting away from is prognostication, is when is this person going to die? I just don't go there with families. And I tend to say goals of care. I tend to say end of life. If it looks like, I'm really quite sure it's, we're in the last 3 days. You can usually tell if somebody's going to die if they're in the last 3 days. But do I know whether that person with severe dementia or frailty is going to die in the next 6 months? Have not a clue. And when I do my advanced care planning, particularly with families, I will say, look, we do this with everybody, but I'm often wrong about when somebody's going to die or not die. So it's not about that. It's about care. So I'm not a fan of prognosticating when somebody's going to die, because I've been wrong too many times and have called that relative out from Sydney and had them stare at this poor person for a week, and then they get hungry and want breakfast, and I have to stop the pump. So, just by the way, I just don't do that. Anyway, okay. So then we get to what's called the palliative approach to care. This is, again, from the Lynn and Adamson model. This is the Joanne Lynn that I was telling you about in Adamson, 2003. This is a very popular model that people use to describe the change in the way we're viewing palliative care. Now, it used to be treated and treated, that was it. Okay, now that still happens, I know. I'm a little unstable. Hopefully I'll come back. I know that still happens. However, really, because 43% of deaths are in old people, what's changing is we have to change the way we think about how we do this. So, for instance, I had a gentleman recently who he is very much at the end of his life. We've had lots of discussions with his family. He's very disabled with a cognitive degenerative condition. And we, I'm very comfortable, and so is the family, with not giving him antibiotics. That is a really important thing, because his quality of life isn't flash hot. However, so he gets cellulitis. Do you treat? Do you not? And it was cellulitis that was causing pain. So we had to have a discussion as a team, again, as the family and us as a team, to say, so are we going to treat or not? The family, we had a long discussion, and we did decide to treat, because it was about comfort. That cellulitis was about comfort, not about prolonging his life. Now, when he gets pneumonia, I am not going to treat. I just recently had another gentleman who had a stroke. He wasn't swallowing, he had dysphagia, and we had had some really good advanced care planning discussions with his family. So when it came to the time when he had this horrible chest infection because of aspiration pneumonia, everybody's prepared for it. You know, we're going to make sure he's comfortable, do everything that I'm going to talk about shortly, but actually I'm not going to do the antibiotics for him. So I guess what we're talking about is it's no longer is he palliative or not. It's actually about, are we providing the best care we can in this situation for this particular person? I know that's, for a lot of nurses, this is like just telling you to suck eggs, and I don't mean to be like that, but I think it's really important for us not to say, are they palliative or not? It's just, what's the care that they need? All right, so now I've based what I'm going to be talking about now on the principles of guidance for last days of life, the Te Rare Whakapari. Sorry, I didn't say that correctly. This is from the Ministry of Health. I've decided to use very clearly these guidelines because it is very important, I think, for us to all be on the same page. And I do think that New Zealand's use of guidelines for end-of-life care has made us provide better care, again, as our research was showing. So let's move on. Okay, so this is baseline stuff, but although you know this stuff, it's really important not to gloss over it. So the first thing is, I would say the first thing is spiritual health, and that's where, if I have a chance to talk to the person or their family depending on the situation, I want to know who they are. I want to know who they are spiritually. I want to know who they are. So not just about religion. This question is about who they are in the world. And then the other is the Taha Whānau, the extended family health. I cannot tell you how absolutely imperative it is to have that discussion with the family. If you do nothing else, you've got to sit down with that family and have that discussion. It changes the whole dynamic of being able to provide the care that's needed in that situation. Tihaha Hinarora, I'm going to slaughter some of this, but mental health assessment of the person's preference of care. Now, this to me can be a wee bit controversial. I, as a 50-some-odd, I'm not going to tell you how old, I'm old, but not that old. So as a 50-some-odd year-old person, if you ask me, where do I want to die? I would say to you, I want to die in my home. However, my mom, who has dementia, is in care. There is no way my mother could die at home because of the, I'm going to focus on, it's the safe part of things, so I'm going to focus on this. So physical health is, so recognizing that the person is dying, we'll talk about this in a second. The other thing that's really important is, who does that family or that person call when they need help? So a lead practitioner, it doesn't have to be a GP or a specialist. Absolutely, I actually think nurses do this really, really well, so that you're the contact person, you're the coordinator, you're the one that they can call. I think it is really helpful. I often will provide information to the family so that they can contact me when it's really at the end of life, because it makes a huge difference. So if you got to do a good assessment, that's basic. Anticipatory prescribing, we're going to talk about that in just a second. What does the person know, understand, be able to comprehend, have the capacity to comprehend? What does the family know, understand? And I will tell you, one of my favorite questions to ask in this situation is, what is your understanding of? Whether it's from the person or from the family, what is your understanding of this situation at the moment? Man, you get a lot of great information out of that. And then if I say, what is your understanding of, and then be quiet and just let them talk and give them the space to talk, we really get on the same page really quickly, because I understand what they understand. And, for all of us as nurses, we've been in situations that are curly. I've certainly been in situations where people have been discharged to hospital to die in residential aged care, and the family has no idea that that's what it says on the discharge summary. So it is so important to get what do they know. Food and fluids, we'll talk about availability of equipment, and then consideration of cardiac devices. I will just make a mention of the cardiac device. On the death certificate, I have to write whether they have a pacemaker or not. Just note that. Please note whether they have a pacemaker or not. It really makes it a lot more helpful for anybody who does the death certificate. And then any care coordination. It's basically about care coordination. Okay, now I'm going to talk about heart failure quickly. Again, we only have an hour, so I don't have time to deconstruct a lot of this stuff. But I think one of the things I want you to know about heart failure is that when you are at grades 3 and 4, your median survival is 1 year. I mean, think about it in terms of somebody who has cancer. People that are at grade 3 and 4 with heart failure, they really are palliative. And often, one of the tricky parts about heart failure is this, and I find this with COPD as well. When I have advanced care planning discussions with people with heart failure and COPD, it's a very different conversation than having that with somebody who has cancer. And in some ways, when I have that end of life, the advanced care planning discussion with somebody with cancer, it's like I got to convince them that they're still going to be alive for a while. It's the opposite with somebody with heart failure and COPD. I got to kind of convince them that this is going to kill you. Now, in a nice way, I don't say it like that, just by the way. But in a very nice way, in a very diplomatic way, to try to get their understanding of what it means to have this disease. So the other thing that I wanted to show is that in the last 6 months of life with a person with congestive heart failure, just like I showed you at the beginning, their symptoms are just going to be as bad as anybody else who's dying of anything else. And so they get pain, they get confusion, they get shortness of breath, and it does get worse as things go along. So one of the things to kind of think about is, when do you start really thinking about a palliative approach to heart failure? Advanced age, of course. That person who's going in and out of the hospital all the time because they're getting fluid overloaded, and then they go in for the IV furosemide, and then they come back. So New York Heart Association classification of 4. Poor renal function, that's a real clue, of course, that they have poor perfusion, their heart's not working well. They're starting to lose weight. They're like anybody who's dying, they start to lose weight. They have, their sodium is also not keeping, isn't unable to keep up with the diuretics and also with the fluid overload. And then, so problems for they're often their whole lives. They're on lots of meds, usually for hypertension, tension. And then you start realizing that their blood pressure is like 100/80, 100/70, 190/60. So it's easy to miss that, but it's a really important thing to start getting rid of those antihypertensives at the end of life. It's about deprescribing as well, of course. So if we're talking about COPD, when do you start thinking about a palliative approach for these guys? They start losing weight. Again, it looks like death. Funny that. They start losing weight. Their FEV1 is less than 30% of predicted. They're also going in and out of hospital. They often need long-term oxygen therapy. I'm not going to talk a lot about oxygen therapy in this discussion tonight, unfortunately, but it's a real curly one as well. Evidence of cor pulmonale. So those are some things to think about for a palliative approach for somebody with COPD. I do want to talk a little bit about the difference between cachexia and starvation, and it's a real conundrum for those of us that work with frail older people. Are they starving or are they dying? And it's not always absolutely perfectly clear. So if when you are dying, when your body is shutting down, your cells spit out cytokines that basically make it so that you don't absorb the nutrients that you're eating. You're not even hungry to have them, to even take those in. But one of the things that for me as working with frail older people is I have to do interventions to say, okay, so I'm gonna do a whole assessment. I can't just let this slide by. I have to do an intervention to see if I increase their calories, look at their teeth, look at their labs, do a whole assessment. And if I increase their calories in a month and I come back and they're still losing weight, then I'm thinking more cachexia. But 75% of the time, if I increase their calories and we really, as a team, look at all the factors that might be going into this weight loss, and I come back and they've gained a kilo, then I know that we're looking at starvation. So it's not an easy thing, and you don't want to just throw supplements at it. You want to start with increasing the calories that's in their normal food. So things like creams and smoothies, and making sure they're getting the food in, making sure their teeth are okay. So there's a whole process within trying to figure out, is this cachexia or is this starvation? So just a note about that. Okay, recognizing dying. This is from the end-of-life guidelines. There's a look, and I think for those of us who work in aged care, there's a look, and it's that kind of novice to expert thing as well, I have to say, for those of us that do a lot of care for people that are dying. They start getting very weak. They start taking to their bed. They start refusing food and fluid. They often have swallowing difficulties. Now, that's kind of at the beginning of the journey. At the end of the journey, they start getting mottling in their feet because their circulation's shutting down. They often are cold. The other thing I find that kind of upsets families, that makes them worry, there's a couple of things. One is they're getting cold and clammy. Well, particularly if somebody's dying of pneumonia, they're probably dying of sepsis as well. And so that cold and clammy thing is basically vascular collapse, if you ask me. And so it really is, they do get cold and clammy at times as they're getting into those last few hours. The other thing that I talk to families about very clearly when I'm in the process of, yes, this person is actively dying, is I try to have a very frank conversation with them about what death looks like in a very kind and loving way, hopefully. For instance, really it's unavoidable. So I try to have that discussion with them.
Michal, we just missed that last bit. Sorry, you cut out.
I'll try it again. Yeah. So hopefully, am I back? Yeah, cool. Basically the secretions at the last are very, very distressing to families, I find. It's one of the most distressing things. What I try to do is let them know that, at that point, usually the person is comatose, so they're usually not with us, that they don't feel, it's not distressing to them, that it's really distressing to us, that we've given them as much meds as we can to try to dry them up. But I find that really helps families to understand this is normal. What they're looking for, I find, is they're looking for what is normal. Oh, this is normal. This is what happens when people die. And that's really helpful. Okay. Agitation and delirium. Okay, now this is a bit controversial, and I'm gonna show you what the guidelines say, and then I'm gonna show you some recent research, because I think you'll find it interesting. So the guidelines basically say that when somebody gets terminal, now there's a term called terminal delirium or agitation. In my population, is that terminal or is it not? Are they agitated or delirious just because of other things? So the very first thing for anybody who's agitated or delirious, and particularly in older people, is, are they in pain? Do they have urinary retention? You got to just go there first. Have their bowels moved? And also sometimes, and I've seen this a few times with some people in aged care, they're freaked out about the possibility of dying. So there's a whole spiritual issue here that I've found hospice really helpful with, to tell you the truth, the counseling, because, you know, it's pretty scary. So a really good assessment is absolutely necessary if somebody gets agitated and delirious. It's all that basic stuff that we know. And the nurses that I work with know that when they tell me somebody's seeming delirious or agitated, the first thing I'm going to ask is pain, urinary retention, fecal impaction. You know, I want to, you know, I need to know kind of what's happening in the last few days. Now, if you've done all that and you're pretty sure that this is, it could also be from opioids, but we'll talk about that in a second. What is recommended is a PRN dose of 0.5 milligrams of haloperidol. Now, this says every Q hours, maximum dose of 5 milligrams in 24 hours. I never give 5 milligrams in 24 hours. That's a lot of haloperidol. So what I will often write when I'm prescribing haloperidol is, or any other kind of end-of-life med, is the maximum dose for the day. So, you know, 0.5 milligrams, and I might say maximum dose of 2 milligrams for the day, you know, something like that, from all sources, because we're also going to talk about syringe drivers here in a second. So now there's the conscious, delirious, agitated person. Again, you're talking about haloperidol. Then if you give haloperidol and then you also give some midazolam, most of the time that will do it, particularly if you're doing the midazolam subcut with a syringe driver, most of the time that will do it. If that doesn't do it, you might want to think about Nazanan. Nazanan can be really helpful. It does work. I don't use it that often because I don't need it very often, because haloperidol usually does the trick, but it's something to think about. It's every once in a while you get the person who's agitated, but they're not really conscious. They're kind of semi-conscious. And that's when I'm going to be thinking about subcutaneous midazolam. I find that really helpful, either with a syringe driver or just as a subcut one-off PRN. Okay, so let's talk about the controversies. So the controversies about using the common stuff that we use all the time, and what she looked at.
Again, sorry. Just when you changed over slide.
Okay. Am I back? Yes. Sorry about that. My heart goes out to all you rural nurses with poor web connections. So what she kind of made a big splash, by saying, look, it doesn't look like haloperidol or risperidone did any better than placebo for those with end-of-life delirium. That was very controversial. But if you look on that on the right graph, there was a difference. It just wasn't statistically significant. So that's, as an academic, you kind of start going, oh yeah, but if you had a larger sample size, she only had a sample size of 100. You know, if we had a larger sample size, would that have changed things? And personally, I appreciate this research a lot. I still use haloperidol or risperidone. I actually quite like risperidone. On the other side is another one from a guy named Hui. And what they looked at is the effect of lorazepam with haloperidol versus haloperidol alone for the agitated, delirious patient. And you can see there that the delirium went down quite a bit. So again, I'm not as keen on the lorazepam myself. I would rather use the midazolam. It's a much cleaner drug, actually. But you can see that it is a controversial area. There isn't, I think, clear directions yet. So in order to assess for delirium, I quite like the 4AT delirium screen. We used to use the confusion assessment method, but man, this is so straightforward. It's really clear. I really like this. So just if you do need a delirium screen, the 4AT is kind of the one we use these days. We're going to talk about pain. Pain is important, of course. It's one of the things we think about the most with palliative care. The first thing about pain is just to look at them and to assess them and to see, are they different? And that's the family, are they different? And again, I work with a lot of people who can't tell me if they're in pain or not. And so a lot of that is just observing and seeing what they look like, and, you know, do they look like they're uncomfortable? So the first thing is, you know, to look at any underlying causes. I would really encourage you to do a very thorough pain assessment. This is one out of the end-of-life guidelines. There's a million out there, but this is just one. Really helps you understand what you need to treat and why. This is another example of a tool that can be used. It's the pain assessment in advanced dementia, that's called Pain. And again, all it is just articulating what you see better and putting it into a score. Now, the right drug for the right pain. There's nociceptive pain and neuropathic pain. You've all heard this somewhere along the line. Basically, nociceptive pain is any pain that is from organs, deep tissue masses, deep lymph node issues, skin, bone. It's pretty much any pain that you're talking about, except for anything that has to do with nerves, and that's neuropathic pain. Usually it's described as nociceptive pain is usually described as ached or throbbing or dull, cramping, where with neuropathic pain, it's burning, it's shooting, it's pins and needles. Okay, what do you do? So the first thing is non-pharmacological approach first. Heat, massage, anything you can possibly do. I've got a gentleman right now in one of our facilities who has lung cancer, but he also has a long-standing arthritis in his neck. So it's hard for me to know when he talks about pain, is this the lung cancer pain, or is this the long-standing arthritis pain that he's had in his neck forever? I will say that one of the things that is surprisingly helpful for arthritis pain in particular, but other types of nociceptive pain, is diclofenac gel. 1%, only 1% is of this. Even if the person is comatose, that paracetamol suppositories for fever is really helpful for comfort. Don't forget about depression. That depression, when people are depressed, they feel they don't cope with anything and they don't cope with pain. So I will often treat depression quite aggressively in the older people that I work with. Now, for the neuropathic pain, I try diclofenac gel. You can try capsaicin. I'm not a real fan of capsaicin cream, the Zostrix stuff. Regular paracetamol, you know, all this makes sense. Now, it used to be that our first thing that we tried was the TCA, the tricyclic antidepressants, amitriptyline, nortriptyline, and basically we had to do that before we could go on to gabapentin. Gabapentin can be really helpful for neuropathic pain, but it's really hard to titrate up and titrate down. We now have access to pregabalin. Pregabalin is a much easier drug to use, to tell you the truth, because the doses are lower and it's not as hard to titrate up and down. I have seen in some anxious patients that pregabalin also has a little bit of anti-anxiety in it that has been really helpful. So don't forget about the gabapentins and the pregabalins, and then the carbamazepine for people with neuralgias can also be helpful. So this is the good old pain ladder. I'm going to tell you, again, controversy, pain ladder, controversy. So it's just a few things to kind of think about. Of course, you're going to do, non-pharm stuff. Of course, you're going to do paracetamol. Of course, you're going to do, now, codeine. Let me talk about codeine. Codeine, the metabolites of codeine is morphine. One of the things about codeine is it dries up every bit of moisture in any kind of gland that you have, which is great if you have a cold, but it's really bad if you're trying to have a bowel motion. So one of the things about codeine is it is horribly constipating. Yes, morphine is also horribly constipating, but not quite as bad as codeine. So in our opinion, for older people's care, I just don't do codeine. If I'm going to give an opioid, I will give them some kind of morphine or oxycodone. Now, what about tramadol? Tramadol, some people tolerate tramadol really well. I can tell you in older people, there's a lot of delirium that happens with tramadol. So I'm very reticent to think about tramadol unless somebody's come in with it and I know that they tolerate it well. So it's not my go-to drug. It might be my last resort drug, but it's not a go-to drug. The other thing to remember about tramadol is that if they were taking an SSRI and a tramadol at the same time, you can get serotonin syndrome. And with serotonin syndrome, one of the things that they get is they get clonus, and they get really rigid, and they can get bruxism. So just remember that it can throw people into a serotonin crisis. Not a good thing. There is buprenorphine. That's new to New Zealand. It's been around forever in other countries. I haven't used it much. I do know that some palliative care people are really, really happy with buprenorphine. There's some research to say that it works really well for comfort care pain. But again, it's just, I've never used it, so I don't have a lot of comment on that. And then we get to the opioids: morphine, oxycodone, hydromorphone, fentanyl, and methadone. Now, what is the difference between oxycodone and morphine? Not much. The oxycodone is slightly, not a lot, but slightly better for somebody who has some renal impairment issues. But other than that, it really is, there isn't much difference. It's a lot more expensive. Some people who don't tolerate morphine because of hallucinations and other issues, sometimes they'll tolerate oxycodone better than they did morphine. But really, your first go-to should be morphine, and it should be oral morphine, so that you start with oral morphine, short acting. You might want to then think about subcut, PRN, and of course then you're going to get in syringe driver. Now, fentanyl patches. I was reading about this because it's interesting. I've been doing some work with Health Quality and Safety Commission and their drug atlas. I'm telling you, it's very interesting. You should go look at it. There is a huge variation across New Zealand about who's using fentanyl patches and who isn't. Massive variation. One of the DHBs, who will remain nameless, uses a lot of it. And from what I understand, there was a huge push to say, don't use oxycodone. So now there's a whole lot of fentanyl patches, where other DHBs, I mean, we're talking a 10 times difference in using fentanyl patches. In the palliative care handbook from Hospice New Zealand, what they say is nobody should be on a fentanyl patch that isn't already on morphine. So look, there's a lot of controversy about fentanyl patches. Some people love them. So just be aware that there's a lot of controversy about it. I've just put in here for you, I'm not going to go into it much, but basically the conversion of one drug to the other. So this is kind of how it works. Morphine, first line opioid, particularly if they have good EGFR. And then what I usually do when I first start, let's say that I've identified somebody who's dying. They clearly in the last few weeks of their life. I will usually again start with a PRN, 2.5 milligrams to 5 milligrams every 4 hours. And then as things move along, then I start getting into the regular subcuts, possibly, but always having the breakthrough there for me in case I need it. If they have renal impairment, fentanyl is a better drug for people with renal impairment. We had a woman with an EGFR of 3, and she was on fentanyl. She lasted 6 months. That's a whole nother discussion, which we won't go into. So renal impairment. So fentanyl patches would be what you'd want to think about because it's with renal impairment, it is a little cleaner. and I'm moving on because I'm running out of time. Nausea and vomiting. First line is all the normal stuff: haloperidol, metoclopramide, cyclizine. Again, you want to think about Nazanan, and if it's really, really bad, Nazanan's your one. You really want to think about Nazanan for that. Secretions. Now, I found this really interesting. Again, just how different people practice. Certainly, hyoscine is what we want to think about. Subcut. If I have somebody who's actively dying, then, and I know that they're going to be dealing with secretions, I'll do 20 milligrams twice a day, maybe 3 times a day. What's interesting about these guidelines, a maximum of 120 milligrams in 24 hours, that's a lot. I've never done 120 milligrams in 24 hours. That's a lot. So I thought that was interesting that there's such a bit of a variation, but certainly, you know, this can be a really helpful thing for the distress of the families with end-of-life secretions. So breathlessness, one of the most difficult things about working with people that are dying from COPD is breathlessness. It's so difficult because they're breathless for a long period of time. Now, I have had good results with taking oral morphine, maybe 5 milligrams, maybe once or twice a day. Sometimes it basically just suppresses that CNS drive for shortness of breath. So don't forget about the morphine for shortness of breath, even if it's over a long, long period of time. It really can make a big difference. I've even seen it with somebody with tramadol, which was surprising. But you know, the morphine's the go-to for that. I want, when do we start fed? They're not eating anything oral. They're nothing, you know, there's no medication, very little fluids. You know, they really are at that point of not being able to take things orally. Then I'll think about a syringe driver, or if they have dysphagia, you know, any kind of difficulty swallowing. GI obstruction would also be, or anybody who's not absorbing oral medications for whatever reason. But for me, it's really about that level of consciousness and their overall, are they able to take any other types of meds or not? This I've gotten from the Ministry of Health guidelines for syringe driver management, palliative care in New Zealand. It's really a good, very helpful thing. There's a lot of syringe driver training that happens through hospices. This is a really good guideline, just by the way. Okay, so this is what is suggested: 10 milligrams of morphine over 24 hours. If opioid naive, that's what you start with. If on oral morphine, then you have this 2-to-1 rule. If they're taking 60 milligrams of morphine over 24 hours, then you want to give 30 milligrams subcut over 24 hours. But you also always, for me, I always want to have anticipatory prescribing so that I also have PRNs for breakthrough and for everything else about this end-of-life journey. So the recommendations are that morphine, PRN, your breakthrough. So you've got your pump going. Let's say that you've got 30 milligrams of morphine going in your pump for 24 hours. So you want to do 1/6 of that dose, either oral or subcut. Usually it's subcut by that point if they're on a syringe. So that would make it 5 milligrams subcut PRN. Some people do every hour, some people do every 2 hours. Yeah, I think the guidelines are 1 every hour. I think that's a little much. And somebody will probably tell me that I'm crazy, but so 1 to 2 hours, 5 milligrams, 1 to 2 hours. Again, how I prescribe it is to say maximum. Like, so this is what I want you to give every 1 to 2 hours, but don't go over, 80 milligrams in a day or 60 milligrams in a day or whatever. My syringe driver cocktail usual go-to is 10 milligrams of morphine, 5 milligrams of midazolam, 0.5 milligrams of haloperidol over 24 hours. I rarely have to change this unless somebody is very nauseated. Then I might think about Nazanin. If somebody is really agitated, I might really increase that midazolam rather than the morphine. If somebody's in a lot of pain, I might increase the morphine rather than the midazolam. So there is a, really depends on what we're dealing with. Depending on if they've had morphine already or are they morphine naive, all of that needs to be taken into consideration. Do you do 10 mils or 30 mils of diluent in the syringe? The guidelines, and I agree with this, are you use 30 mils in general, particularly though if you're using methadone, cyclizine, or ketamine, because those can be irritating, so you want it to be more dilute rather than less dilute. What you don't put in a syringe driver, prochlorperazine, diazepam, or chlorpromazepine. I never use that stuff. So any of those, because they're too irritating, and that's why you would absolutely never put those in a syringe driver. But there are the other drugs that you have. Again, people will put the hyoscine in the syringe driver. There's nothing wrong with that. The guidelines basically are saying don't put more than 4 drugs into one syringe. I tend to put 3 in and use the hyoscine. Usually what happens is the nurses have a subcut line for the syringe driver and a subcut line already in for any other kind of PRN drugs, and that's why I'll do other drugs. With methadone, I don't ever do anything with methadone without calling the palliative care specialists. I don't feel comfortable doing it without calling the palliative death. So this is the final thing, is you do not have to call the ambulance or the police. Let's see if I've just died. So let's see if I can come back. Okay, here we go. It's helpful to note the time of death. Please tell me the time of death. Really, really helpful. Contact the GP/NP. This can wait until the morning if the person died overnight. I think a lot of people think, oh, we got to do this right away. It's like, there is no hurry. There is absolutely no hurry. In fact, one of the things that I say to families right away is like, there is no hurry. You can stay as long as you want, whatever you need to do, whoever you need to call. Now, this is really important. RNs can determine life extinct, and the body can be removed by the funeral director. So the GP/NP does not have to see that body at that place unless it's a coroner's case. Now, I haven't put that in there, but if it's a coroner's case, you absolutely need to get the police in there, and there's an 0800 coroner number. And coroner's case are suicide. Coroner cases are any suspicious deaths. Kids, absolutely coroner's cases. Any unusual circumstances, don't be afraid to call the coroner. They're actually really lovely. And so they'd rather you call them than we find out later that this should have been investigated by the police. So, but the run-of-the-mill person who you know and everybody knows, and you've done great advanced care planning, and they died, you don't have to have the GP/NP see that body. You can call up the funeral director, say, please take the body. Now, the NP/GP does not have to actually see that body if they're the regular provider, if they've seen it within, a reasonable amount of time. I would say a week myself, or a few days. They can do the death certificate without seeing the body, unless it's for cremation. And 80% of deaths are for cremation anyway, so most of the time we have to see the body. So if the body is for cremation, the GP/NP or whoever's doing the death cert is going to have to see that body. What happens for us sometimes is the body is removed because of the RN has, said it's life extinct. And then I have to go to the mortuary to view that body, so that then I can do the death certificate. So just kind of be aware of those funny little things about death certificates. I love death docs. You've got to tell your GPs, NPs that you work with to use death docs. It is fantastic. It's my job on the face of the earth to tell you to use death docs. It's easy to use. You can print out as many copies as you need, so that give one to the family, give one to the facility, give one to the funeral director. And in fact, a a electronic copy goes to the funeral director anyway, so that's also really great. Or, you know, the aunt wants a copy, you know, it's really, really helpful. And it's online all the time, so I can always go back to it even if I'm not at the facility. I can, if it's just a death from somebody that's been expected and I know them and they're not for cremation, I can do the death doc at home. Honestly, death docs, it's the way to go. Just by the way. Thank you very much. Oh, and I have 1 minute left, but I'm really happy to answer and ask any questions. I'm happy to ask questions. I'm always asking questions, but I'm happy to answer it too.
Oh, fantastic, Michael. Thank you very much. We did lose you a few times, but I hope everyone managed to get the majority of it from your slides as well as what you were saying. Yeah. We've got a few questions all on the chat.
Yeah.
So the first one, as somebody asked, how old are you actually?
I'm old, man.
Answer. And then we had Sora. There was one from Sora, which was quite a wee while ago. So she said, Michael, if there's any time here for you to cover your own personal journey witnessing so many deaths, I would love to hear how this has impacted on you, how you deal with situations that triggered. I appreciate you've lots to cover. Thank you.
Oh, cool. Look, I'm not going to spend a lot of time on this, but I will say a couple of things. I think the most meaningful thing that I do in my life is help people at the end of life. It does feel like being a midwife to me, personally.
We lost you when you said it's like being a midwife to you.
Okay. I think hopefully we're back, but for me personally, it is the time when I am and the people around me are the most real, and I feel very privileged to be there when people are at their most real. So that's what I think. So what else we got?
We've got what type of non-drug interventions are the best for people in palliative care, e.g. diversional therapy interventions?
Yeah, look, it depends on what you're trying to do. I think this is the time to get family and friends together about what it is. I do agree with diversional therapy. And I also, you know, just getting people out so that they feel normal again for, you know. I also will, if the person has the cognitive capacity, I do find the spiritual guidance and counselors from hospice really helpful. I have a gentleman, I'm just telling you, with the lung cancer. He's going to hospice for their art therapy. It's fantastic. Now he's got cancer, so they took him. And there's a whole discussion here, which I will not have tonight, about who gets hospice and who doesn't. But I will say that I agree with anything that gets them getting creative, I think is important. Anyway.
We've got, does hyoscine make much difference? We've
that's a good question. Yeah. I don't know. Sometimes it does, sometimes it doesn't. That's why I always have to have that discussion. I always do it. I do it up to 3 times a day. You know, when people die, they get a death rattle. And it's not hurting the person that's dying. So it is, I think it's a lot of communication.
And then the next one we've got is, do you use dexamethasone for drying up secretions?
Oh, that's a really good question. I don't, actually. And I think that would be a really just good discussion to have with a palliative care specialist. For me, dexamethasone, really the only time I'm going to use it is for brain tumors to decrease the swelling in the brain tumor. But yeah, so that's interesting. I haven't.
There's a few people commenting about getting access to your slides.
Fine with me. I don't know how I would do it.
I'm sure Andrew will help us with that, because the presentation will go up on YouTube once it's been edited. But yes, we can figure that out with him. Lots of people thanking you. Very interesting. Really enjoyed your talk. We've got here. Oh, we've kind of answered that one. Kim's asked, what are your feelings on hyoscine? Hospices often no longer prescribing.
Yeah, I know. Look, I'm very much in two camps about that. Yeah, it doesn't. I agree. Does it make a difference or not?
And Sue hopes you're enjoying your sabbatical.
I am.
Got to get.
I feel like a new woman.
I would love to know more about the research you mentioned. Do you have a link on where we can read or get a copy of it?
Yeah, if you go to Google Scholar and put in Boyd and you put in it's 2019 and it's BMC Geriatrics, and you should be able to find me. So if you put in my name, BMC Geriatrics 2019, it should come up.
Okay. Do you continue dexamethasone once they have stopped swallowing?
Oh, that's a good question. Again, I don't use it very often, so I can't actually answer that, unfortunately. I'd love to talk to a palliative care specialist about that.
And then we've got one here. In rural, where there's vast geography between lead carer, patients and clinicians, do you have a tool recommended to join up the distances?
Oh.
These questions are getting good.
I know. Look, I don't have a tool, but I do think it's really important to have that person who's coordinating the care really, really clearly identified, so that the family knows who to go to, and then that person. Am I back?
You're back now, yeah.
Oh, cool. All right, guys. Well, I'm gonna sign off. Thank you so much, Catherine. It's been great to see you, and it's been nice to see everybody.
No, it's lovely. Thank you very much for your time tonight, Michael. Enjoy the rest of your time on your sabbatical.
Okay, bye, guys.
Take care. Bye.
Bye-bye.